Good afternoon. My name is Scott Nicholson with the Judy Nicholson Kidney Cancer Foundation, coming at you live through the power of the internet. And today I'm talking with Dr. Hans Hammers of the University of Texas Southwestern. And Dr. Hammers is doing some incredible work with clinical trials, specifically a trial called Checkmate 214. And today he's going to tell us all about it. Thank you for joining me today, Dr. Hammers. How are you?
Hi, Scott. Thank you so much. I'm doing well. Thank you for having me.
Absolutely. Thank you for being here. So why don't we start with you telling us a little bit about what it is you do?
Sure. So I'm a physician scientist. I trained at Johns Hopkins, was there on faculty for quite some time, and then moved to UT Southwestern roughly 2 years ago, and leading some of the clinical research efforts here in kidney cancer. And I've been involved for some time in immunotherapy trials with kidney cancer.
So what is Checkmate 214?
So Checkmate 214, I think, is really a landmark study in kidney cancer. It's the first time that we pitted pure immunotherapy against really the standard of care for most kidney cancer patients, which is Sutent. And it really beats Sutent in a disease group or in a risk group of patients that really encompasses most of the patients. So 70% of kidney cancer patients that are treated with recurrent metastatic disease are what we call intermediate and poor risk. And this therapy was clearly more effective when compared to sunitinib in this patient population. It's a very large trial, enrolled more than 1,000 patients, and the immunotherapy was a combination of two drugs, Opdivo and Yervoy, and was compared to Sutent as normally delivered with a 4-week on, 2-week off schedule.
Wow. Can we take a step back for a second, though? What exactly is immunotherapy in layman's terms?
So immunotherapy, it's a very broad term, and I think the definition really very broadly is essentially a therapy or drugs that manipulate the immune system, the patient's immune system and the immune response. Currently, I would say what we typically associate right now with the term immunotherapy are immune checkpoints. So drugs that target, in particular, two pathways, PD-1 and CTLA-4. These are receptors on the surface of immune cells, and immunotherapy really are antibodies that block these keyholes that the cancer can engage in and turn off, if you will, the immune response. So it's really a way to unleash the immune system. These are what we call immune checkpoint inhibitors. And I would say quite notably so, the recent Nobel Prize in medicine actually went to the two discoverers of these pathways. So one went to Japan for PD-1, and one went to Jim Allison here in the United States for CTLA-4. So I would say very remarkable, and really antibodies that target these both pathways were combined in Checkmate 214.
I see. And Doctor, why are you excited about this trial?
Yeah, so exactly. So it's, immunotherapy in some form has been around for a long period of time. I would say the initial wave or the initial approach of immunotherapies was really focused on creating vaccines. So to educate the body, the immune system, to see a target, see the cancer. That certainly has worked really well in infectious diseases, but it didn't work so well in cancer. And I think the critical insight that really changed the way we treat cancer, not only kidney cancer, but cancer in general, really is that oftentimes our body actually can see cancer because it is different than the normal cells. And the critical intervention really is to unleash the immune system, take pathways away or block them that the cancer uses to actively turn off the immune response. So it's a really unique approach, and has had consequences across different tumor types. the treatment for kidney cancer since the 2006 timeframe really has been dominated by agents that target blood vessels. So Sutent is one of these classic drugs, Votrient, Carbomatics, all of these essentially target blood vessels. But these treatments, they were really palliative in nature, meaning, yes, they can shrink tumors, they can reduce tumor growth, can keep it steady for some time, but these pills typically don't eradicate kidney cancer, and they work for some time, and then they almost inevitably will fail. So this was the first time that we really, in a large phase 3 trial, put a therapy up front that, if you were lucky enough to respond really well to, can potentially control your cancer for a really long period of time, even, in fact, if you stop therapy. So the difference between immunotherapy and these targeted therapies that we have in kidney cancer, these blood vessel inhibitors, is that the response to immunotherapy can be very durable, can be very lasting, and sometimes we even stop therapy altogether. Patients may not need any further therapy. If you stop the pills, the cancer rebounds, comes right back. And so that's the main difference. Interestingly, the quality of life was also generally better with the immunotherapy than on the pills. But the side effect profile is quite different between these two.
Interesting. Could you explain what a durable response is?
Yes. So durable response, it's just a fancy word for a lasting response, really. It's something that can go on for long periods of time. And I would say the really important aspect of a response in the context of immunotherapy is that you may have what we call treatment-free intervals, meaning there might be times where you don't need any therapy. So let me give you an example. I actually had a patient when I was still at Hopkins who I recruited to the Checkmate 214 study. He was randomized to the immunotherapy arm. He just got one dose of nivolumab, ipilimumab, developed a side effect that made him choose to stop therapy. And he had a fairly aggressive cancer, had very rapid progression in the lung when he started. And so we stopped therapy and just watched him. And all his lung lesions melted away. And this is now more than 4 years ago. And he has not needed any therapy since. So I think, these kinds of stories are really, quite impressive. And I think they really illustrate the potent approach that immunotherapy can deliver.
Doctor, what would you say are the benefits to this type of trial?
So let's talk about some numbers. So again, it's important though to remember, so this immunotherapy is now FDA approved for what we call intermediate and poor risk. So intermediate and poor risk are patients who are either recurring within 1 year of the original diagnosis, original tumor was removed, and or have additional lab abnormalities or decreased performance status. So they're either not doing so well, or they're anemic, their red blood cell counts are low, white blood cell counts are high, platelets are high, or they recur within 1 year and start treatment essentially within 1 year after the initial surgery. And that's roughly 70% of patients. If you get treatment with this combination immunotherapy, your chance to respond, meaning to significantly shrink your tumors, very significantly, is around 42% for the immunotherapy versus 27% for the Sutent. So clearly more active just by response. If you looked at the hardest endpoint there is, which is overall survival, the median survival of patients who were treated with Sutent, meaning out of hundreds of patients, the patient in the very middle lived 26 months. For the combination therapy, for the immunotherapy, we don't know yet. We have an NR, not reached. And I think it illustrates that this is certainly quite exciting. So the two arms are separating very nicely. We don't know yet where the person in the middle is going to be on the immunotherapy arm, but clearly there was an overall survival benefit. And remember, the intermediate and poor risk patients are really the ones that we mostly worry about. So these are patients who sometimes just live months, Some is more in the range of just a couple years. So these are the ones that we worry about the most. Good risk patients are ones where, the disease recurs late, often years after the original surgery. Those patients have, a disease that is typically much slower growing, more indolent. They can even live without therapy, without effective therapy. They can live in the range of years. So it's a very different subset of patients. But that kind of therapy is approved in intermediate and poor risk, and I think the efficacy data, is quite striking.
And are there any risks associated with immunotherapy?
Mm-hmm. Certainly. So, there's a lot of excitement about immunotherapy. It's almost like, sometimes I feel like patients think it's like organic because you can't use the patient's own immune system. But the truth is, it's really like playing with fire. That's the analogy that I like to use. If you unleash the immune system, it can certainly have a lasting and impressive effect against the cancer, but if you take 2 breaks away of the immune system, then it may also direct its force against the host, meaning the patient. So the classic side effect profile is autoimmune disease. And a number of patients requires immune suppressive drugs because the immune system has decided to inflame and attack the lung, the liver, the colon, can be any other organ. And I would say the overall need for prednisone, for example, relatively high dose of prednisone to control these inflammatory side effects is around 35%. So it's a significant number. It's certainly higher than if you give Opdivo by itself. But the combination is also more effective. So you take more breaks off, and you get also more side effects. Nonetheless, the quality of life was better when compared to Sutent. But it is a different side effect profile than the pills. It is something that will not go away by itself. So if patients develop these side effects, really, timely reporting is absolutely key. Because these side effects will not disappear by themselves. So there needs to be an intervention, the start of immune suppressive therapy with prednisone or maybe sometimes other medications is needed.
And what should a patient consider when deciding between a high-dose interleukin-2 or the dual immunotherapy treatment with ipilimumab and nivolumab?
Very good. So, that's a very good question. So let's take a step back. So, high-dose interleukin-2 was developed or actually FDA approved in 1992. So really work by the NIH, NCI, the surgery branch, fantastic work by Dr. Rosenberg and his team. But the truth is, even in the high days of high-dose interleukin-2, only roughly 2% of kidney cancer patients were treated with high-dose interleukin-2. It's a fairly intense therapy, and it is something that needs to be administered in centers of excellence. We did it at Hopkins, we do it here at UT Southwestern, but it is not for everyone. You need to have a good performance test, you need to be fit, you need to have good end organ function. So you should be pretty much without symptoms when you go on this therapy. You should have a disease burden where even if you progress, it shouldn't cause you trouble because most of the time interleukin-2 doesn't work. The response rate to interleukin-2 is around 20-25%, depending on what you look at. But the patients who tend to do the best are the ones who get what we call a complete response, a very deep response. That's roughly 7 to 8% of patients in the single digits. We saw complete responses also with nivolumab, ipilimumab. But the sense is, I would say, that the combination checkpoints are just more effective. It's a different side effect profile. High-dose interleukin-2 is really inducing a picture of acute sepsis, if you will, a little bit multi-organ failure, swelling up, water, fluid retention. So it's really in the intensive care unit setting that you get this treatment. versus an outpatient treatment with nivolumab, ipilimumab. So I think it's much easier to make a difference in the kidney cancer population with a therapy that you can give to almost anyone. I have patients in their 80s who I'm treating with nivolumab, ipilimumab, and I'm not scared of it. I follow them closely, but it's not something that I wouldn't be able to deliver in somebody who's, for example, on dialysis, somebody who's older. These patients are all amenable to this kind of treatment.
How long has this type of treatment been available?
So the development took some years. I think it took the industry quite some time to develop. Ipilimumab was first approved just by itself in melanoma, and then later on combined with Opdivo. And then once they learned how to do these trials, they tested it in kidney cancer. Unfortunately, it worked. It was officially FDA approved, April 16th, 2018. And the funny thing is, the reason why I remember it is it's my dad's birthday. So, but it was approved on his birthday.
How would you talk to a patient considering this combination treatment versus interleukin-2?
I think there are two different patient populations that we would normally consider for nivolumab, ipilimumab, and Highdose IO2, although there's a subset of patients who I think could be a candidate for both. As I told you, nivolumab, ipilimumab is approved in intermediate and poor risk patients. So interestingly, the notion is that these therapies are actually more effective in the more aggressive tumors. In fact, there is a subset of kidney cancer we call sarcomatoid renal cell carcinomas, and some nice work from some of my colleagues based on the Checkmate 214 study suggests that in this rather devastating histology, so it's a type of kidney cancer that tends to be more aggressive, less responsive to the pills, responsible actually up to like 50%. So the curious thing is that the more aggressive tumors, the more poor prognosis tumors tend to respond better to immunotherapy with the checkpoints. Those were not classically the patients that we selected for high-dose interleukin-2. So high-dose interleukin-2 studies are typically, skewed towards favorable risk, good risk patients with well-differentiated tumors, patients with lower tumor burden. So I would say a priori, when I see a patient for the first time, I do think they are somewhat different. Now, have I treated patients with both? Absolutely. I do think that they do have a different mechanism of action. I do think there's some data to suggest that patients who responded to checkpoints or didn't respond to checkpoints, they may still respond to interleukin-2. So there might be some different mechanism, and it might be worth trying it in selected patients. With regards to interleukin-2, I would also say, there's a lot of change coming with regards to this class of drug. I think the industry is testing interleukin forms that are pegylated, that are long-lasting, that can be given in the outpatient clinic carefully. And so there are trials ongoing testing pegylated interleukin-2 and pegylated interleukin-10 in outpatients, where you don't have to be in the intensive care unit. It tends to be much better tolerated. And we still have to see what the numbers are going to be in kidney cancer, how effective it's going to be. But certainly I would say as a class, there's really an effort of bringing these drugs out of the intensive care unit into the mainstream, infusion area where many more patients can be benefiting from these drugs.
Could you please share a story about a patient who had a remarkable response to the trial?
So I mentioned the one patient already. There's another patient who was not on this particular trial, but was still using Opdivo and Yervoy, nivolumab and ipilimumab. Young guy in his 40s, has a son, came to me out of the blue, diagnosed with a very large renal mass and the liver full of tumors, like child head size tumors, and And we put him on a trial that actually combines radiation with nivolumab, ipilimumab. And that patient had a major response. So all his liver lesions essentially disappeared. There was a little bit primary tumor left that we resected, and the patient is now free of disease at this point in time. And he had only 2 doses of the nivolumab, ipilimumab. He got some side effects from his kidney. He needed some prednisone, some other immune suppressive drug, and he is doing really well. And he actually published a story in the Dallas Morning News as a reporter, wrote about himself, and I think his story was really appreciated in the patient community because it was a message of hope. So, when he was first diagnosed, his initial doctor said, well, you have to kind of like think about your end of life. And then he came, now admittedly had an outstanding benefit from it, but it illustrates what it can do. He is off therapy for more than a year. This treatment-free interval, hopefully he is cured. I don't know if he is, but hopefully he is. But this is as good as it gets, right? To have just 2 doses of a therapy, stop therapy, and right now you go about your business, live life without any side effects.
It sounds like this research is really changing the way oncologists treat kidney cancer. Is that correct?
Yeah, absolutely. I think there's a big change coming, or has happened already in 2018. There will be other immunotherapy combinations that are moving to the forefront, and I think it is really exciting. I think immunotherapy belongs in the very front, because the intent should be not to just suppress cancer, it should be to get rid of it. And a lot of therapies are moving in the front line of previously untreated metastatic patients, but also we are testing these drugs now in patients with high risk for recurrence. So there's a clear unmet need for therapies in patients with, let's say, stage 3 kidney cancer. Those patients have a recurrence rate of in the range of 30 to 50%. And so currently we are testing these drugs in patients with a large tumor removed, high risk for recurrence, can be decrease the risk of recurrence and improve survival. So trying to use these drugs even earlier in the disease process, I think will be very exciting to see.
Is it still important for patients to enter trials?
Well, I'm obviously biased because I do them, I run them, etc. But the simple truth is, if we want to improve therapy for kidney cancer patients, we need to test new therapies, good ideas in kidney cancer patients. And I thank all of the pioneers that I've been working with, my patients, who participate in some of these trials, and it really makes a difference. It can benefit the patient directly by getting access to these drugs, but it will help the larger community to move these therapies forward and make them accessible. So we strongly encourage patients to participate in clinical trials. And again, it doesn't hurt to just ask. Seek out a specialist, seek out somebody who focuses on your disease, get a second opinion. It doesn't hurt to get a second opinion. Nobody's offended. And then get educated about your cancer, and then make the best decision possible.
Well said. Doctor, I want to thank you for your time today. This has been an eye-opening discussion for me, and I think that our viewers are going to get a lot out of it. I hope that in the future we might be able to do a follow-up interview and perhaps and get you to attend one of our symposiums in the near future. I think that you'd be a lovely speaker at one of those events.
Sounds good. Thank you so much.